Does anybody have anything that they can think?
I just want to remind everybody that trauma scene times are 10 minutes. No, that is not my rule. If you don't like it, you can take it to Dr. Eric Yazel. However, we are going to be held accountable for those 10-minute times. Therefore, I send them to your bosses, and we all know snowballs roll downhill. So please remember, trauma is a 10-minute scene time. If you cannot make 10 minutes, we understand that that is sometimes unreasonable. I need to know why. You're getting better. I am seeing things in there. Kudos to those of you that are putting extended scene time due too. But please, please, please tell me why, because some of the excuses I'm using are pretty creative. Assessments and IV starts are not acceptable per Dr. Yazel and Stan Frank. Because those are things you can do en route, they said.
We'll start with Timmy. I just realized I didn't put the right month on there, so I'm sorry. It's April, but y'all know where we're at, right?
I don't know. Some days I don't even know.
Back, right?
Right. So our first case study, this is not the right report. This is not what I sent. This is last month. That's why it says March. I sent it to Barry. Hang on, let me see if I can pull it up on my. We'll get creative here. If not, I can just talk and you guys can listen to him. Sorry. I searched this. Am I not smart enough?
Can you pull it up in your sent?
I'm trying to do. It's not showing me sent on my Outlook on my phone.
Get the cast off in about 2 weeks from last Friday. Put the poop for another 2 weeks.
Look at in where it says like inbox in that top left corner. That show you what you're sent?
Oh, you're so smart.
I
was trying.
No, I just had to do it a lot of times and couldn't figure it out.
I was trying to hit the other button. Okay, so I'm gonna do this off my phone, so we're all gonna have a great time here. So I apologize, these won't be right, but the first case that I'm gonna to talk about is this was a 56-year-old male that came from TransCare. He called EMS for chest pain and shortness of breath. He was exercising on an elliptical machine and experienced chest pain, shortness of breath. He had to take his own nitro, sublingual, and an aspirin. When EMS arrived, he was in visible distress and he kept saying, "I'm going to die," which we all know that's kind of a red flag. His past medical history was significant for coronary artery disease. He had had 2 prior stents. They did do a 12 lead, which showed ST elevations in lead 1, 2, and AVF with reciprocal changes. They did call the stimulant ahead into IHERN, and they did transmit the EKG via eBridge. The cardiac cath revealed a 99 to 100% occlusion of the left circumflex and successfully stented. He was taken to the ICU in stable condition and discharged home the next day. So all the run times were great. The first call to first medical contact was 10 minutes, EKG within 2 minutes, transport time was 11 minutes, and he came here within 30. The Union door to balloon time was 44 minutes and the first medical contact to balloon was 68, which is remarkable, well under the 90 minutes. And I will say we at Union and the ED have an opportunity. We're trying to look at our organizational goal of door to balloon time. The national standard is 90 minutes. We're looking to go to 60. So what we're looking for with your guys' cases is calling that in. Our ED providers are just activating the cath lab, getting everyone in here, not waiting for the EKG, not doing another EKG when they get here. Those are things we're working on. So we appreciate using eBridge or getting the EKG however you can get it here. So within the HIPAA compliant laws, I won't even go there. But anyway, so because you guys called it in and transmitted it, we were able to get that patient in and out of the cath lab very quickly. So appreciate that. Again, he had the occlusion. So that's it on that case. Next case, this guy or this female came from Terre Haute Fire. It's an 87-year-old female dispatched for chest pain. When they got to the scene, she was lying in her bed. She was ironing clothes and she began having chest pain. No radiation. She just said it was steady chest pain. No cardiac history, no shortness of breath. She was a little diaphoretic, but she had a strong pulse. Her EKG did show the ST elevation in AVL, V2, and V3 with depressions in lead 3. They gave aspirin and nitro. The STEMI alert was called in via iHern. They did do a cath that revealed the 99% proximal LAD stenosis, which was successfully stented. Her EF was 30 to 35%. So she was taken to ICU, stable condition. They discharged her on a life vest and all the appropriate medications. So she followed up with cardiology just recently. She's doing very well. She's participating in cardiac rehab, which is pretty outstanding for an 87-year-old female. Again, on this case, all of the run times were fantastic. The EKG was done promptly. The alert was called in ahead of time. I will say on this case, we did not meet our door to balloon time. It was 105 minutes. And again, this is an opportunity for the providers here. They called the STEMI alert in at 2200. She got here at 2215. The cath lab wasn't activated or MD notified until after the patient arrived, and then they did another EKG. So that kind of wasted some minutes. We could have shaved off quite a bit of time there because she didn't get to the cath lab until 23:19. So there was an hour and 19 minutes that passed there that we could have made up for. Now, cath lab does have 30 minutes to get here, but had we shaved off some of that time, we would have been well under our reperfusion goal. So just of note, opportunities there for us to do some improvement. Otherwise, great job. We continue to advocate for the ED providers to activate the cath lab as soon as EMS calls it in. I know Dr. Jackson's been working very hard at, communicating that with the team members and the ED. And I encourage you guys to keep calling it in, transmitting the EKGs. Even if you're not sure, send it in, call it a STEMI, because we'd rather have them get here and get to the cath lab, or maybe, on the rare occasion that it has to get canceled. I am tracking that just to see, how often that happens. I don't think that it happens that often. Typically, you guys are on point. So keep up the good work. Anybody have any questions? Okay, thank you. Sorry for the PowerPoint problem.
Very.
Bro. Good morning. Morning.
This patient is a Union Hospital patient. It was a 56-year-old male. He lived at home, was not in blood thinners. He has a history of smoking, hypertension, and bipolar disorder. Present history, EMS was dispatched to a local residence for complaints of stroke-like symptoms. Upon arrival, he was fine lying in bed. He reports he was just released from another facility ER, and on the way home, his left side went numb, and he reported having to drag himself to bed. He reported no other deficits at that time. He established his last stone well at 1830. They transferred him to car. Actually, he walked. Hooked to the monitor, sinus rhythm, a GCS at 12, blood glucose was fine, his vitals were fine, but his blood pressure was high at this time. Pulse was 85, everything else looked good. They did start an IV. The Cincinnati score was not completed. They didn't do a VAM because they didn't have those kind of deficits. The stroke alert was called Union ER. Response times were good. You can see those. Depart times, arrived at the ER. They were coming from near Clay County, so it was a little longer response time, but he got here pretty quickly. He went directly to CT3 per the EMS cart. The last known was 1830 per patient. His blood pressure when he arrived was 135/98, but there was no medications given en route. His NIH was initially 1 when the doctor did it here. But it did go up to 3, and I'll explain that in a minute. Had a CT had for stroke at 2016, and it was negative. Teleneuro was consulted, and when she was talking to the patient, she did change his NIH to 3 because he had developed some ataxia and some visual symptoms. At that time, they went ahead, they did advise T&K even with that low NIH, because you usually don't give T&K with those low scores unless it's a life-threatening or I should say life-changing stroke symptoms. But she went ahead and did advise the T&K because the patient, but I'll get to that in a second, I guess. It was a door to needle time of 48 minutes because that delay was in determining if the patient was truly symptomatic. And the patient was reporting he had visual changes in the morning that resolved. So there was a lot of question that his stroke really started at 1830, or he had that morning with the visual changes. Or could the visual changes could have been due to hypertension early in the day. So she spent a lot of time talking with that patient, looking through his history just to make sure of when that last done well was. It did go ahead and do a CT at 2026, and there was no acute findings. But they did do an MRI, and it was completed the next day and showed a moderate sized acute infarct in the right temporal lobe with smaller surrounding infarcts in the region and a small infarct in the thalamus junction. So even though his symptoms were very mild, he was truly a stroke. The decision was made to give the T&K with the low NIHSS due to the teleneuro concern for evolving visual symptoms. And the concern, when she read it, she thought he had an occlusion to the right PCA artery. But it would have been very small, and it was something you could not do a thrombectomy on. So I think this is a very good case that even when someone came in with an NIH of 1 initially, he probably was evolving with where his stroke was in that region with the PCA that was probably occluded at that time. His deficits probably would have grown, and he could have had a more severe stroke. So even in the presence of a low NIH, Dr. Hudson with Vituity, I think she made a really good decision on her evaluation of this patient to go ahead and give a T&K. So I really think that speaks a lot to her ability as a neurologist. I really do respect this decision she made. Even though our door to needle time was longer, it would be excluded from our measures because she really did take the time to look at this patient and to make sure the symptoms were really evolving. And she was very thorough in her documentation of it. I know you reviewed this case too. I think she did a really good job.
She really nailed it.
The patient was admitted to ICU post T&K, and he actually was able to walk out of the hospital. So it was a very good success story, and his vision was intact. That's all I have. Thanks. Do you guys have any questions for me? Thank you.
All right, so this morning it's just 1 case, but 2 patients from the same case. So EMS was dispatched to a residential structure fire. They were advised en route 2 patients. They were inside of the house when the fire had started, but at present we're outside of the home awake and responding. So split it up between 1 patient and the other. So patient 1, so the 911 call, 3:55, they were dispatched 3:56. En route 402, on scene 408. At patient 412, departed the scene 425, and then at Union Hospital, 4:39. So the on-scene time was 6 minutes, so great, we like that. So on arrival, patient number 1 was sitting upright on the neighbor's couch. She stated that she was in the bathroom, saw smoke coming underneath the door, and so that's what alerted her that there was a fire. And she was inside of a smoke-filled room for 5 minutes, and she had to assist her husband to exit the home. Vital signs: 100/70, pulse was 89, 20 respiratory rate, 99% on room air, GCS of 15, normal sinus rhythm. Interventions: 3 lead monitoring, 20 gauge left AC. We didn't really do anything there. So she was activated prior to arrival as a level 1 trauma, based off of respiratory insufficiency, and then possible inhalation burn. So the primary survey for this patient, she was noted to have abnormal airway sounds and a hoarse voice on arrival. EMS stated that her lungs were clear. She had nothing abnormal on their assessment. Crackles and wheezes were noted throughout, and then soot in the nares and the back of the mouth and throat was the primary assessment when she was here. They performed a fast exam at 5/18. That was negative. Burn patients always get a fast exam because they are trauma patients, so we're looking at the whole picture. We're not getting distracted. And then it was decided that they were going to secure her airway. The nurse that was taking care of the patient told me that she could not maintain her secretions. 1 to 2 word statements. They couldn't get anything out of her as to like family to contact. So if she did start that way, this was evolving quickly, right? So they did secure her airway and intubated her. And then the doctor's note in his, for his procedure said that soot was noted to be covering the vocal cords. So lab work, TBC, CMP, ABG, and then a chest x-ray and KUB. Her lab work was unremarkable. Imaging just showed the tubes in place, nothing wild there. So her diagnosis was smoke inhalation and respiratory failure. Trauma surgeon, ER doctor transferred this, called Eskenazi. They accepted care. And she was transferred out at 7:54. So there was a delay there. I think there was weather, I think. So they couldn't fly, and we had to wait for out-of-county transport for this patient. At Eskenazi, they had a bronch, day 1, grade 3 inhalation injury, 3/6, they did another bronch, grade 2 inhalation injury. On the 7th, they extubated and weaned her to room air, and then she was discharged home with family on the 10th. She had no outward injuries, burns, and then just there was no follow-up recommended from Eskenazi. This is a picture that I got from Vanderbilt, just kind of showing the difference in the inhalation injuries. Patient 2, 911 call was 3:42. EMS dispatch 3:57, en route 3:59, on scene at 4:05, at patient 4:10, departed scene 4:24, and then in the ER at 4:36. On arrival, this patient was seated in the back seat of a car. They did document in the report that there was soot observed in the nares, bottom lip, and tongue. Unable to ambulate. This patient had had a knee replacement like days before, which is why the wife had to help him out of the building. History of COPD, and this patient reported his breathing as normal. No complaints. And then it was documented that EMS did reassess, and the patient voiced no shortness of breath, nothing more than normal. Vital signs, 148/84. He's a little tachycardic here, 114. 20s respiratory rate, 89% on room air, GCS of 15. There was no documentation of an intervention for the 89%, but on the IHERN, it did say that he was on 2 liters and he was at 91-92. So 3 lead ECG, 16 gauge in the left AC, no medications or anything of that nature. Also met level 1 criteria for the same reasons. Primary and secondary survey. So this patient had a facial burn and a forehead abrasion, noted to have clear breath sounds on arrival, and deformity to the right wrist. FAST at 510 was negative, but this patient started having some secretions and a hoarse voice, so the decision was made to intubate this patient also. CBC and ABG, and then this patient had quite a bit of imaging. So chest x-ray, pelvis, left knee, wrist, and then CT from head to toe. Smoke inhalation, respiratory failure. It was found that he had a subarachnoid hemorrhage, comminuted fracture of the distal radius, so trauma and ER.
Report falling?
No, but there was a deformity to the.
I know, but
wrist.
I'm saying he's got a head bleed and a wrist fracture.
Mhm.
He felt significant.
Yeah, and so it's hard to there was no documentation where the fire was in that. I don't know where the fire was specifically, or if he knocked something over. I have no idea. So, comminuted fracture of the distal radius. So then he was also transferred to Eskenazi. He left at 6:50. So on the 4th, he had a bronch grade 2 injury. On the 6th, he had a repeat bronch grade 2 injury. The 8th, they extubated, and then they treated him for antibiotics because they weren't sure if he had COPD exacerbation or a pneumonia. Ortho was consulted. They did a closed reduction of that fracture and splinted him. And then on the 17th, he was discharged home. It said either to home with a friend or a hotel. So I don't know if maybe the wife had moved into a hotel situation by the time he transferred. And then just the same. I tried to get follow-up of their specific pictures from their bronch, but I did not get anything back. So anyway, what's that?
Some good burn cables.
Yeah.
So she had a more severe burn than he did.
More severe inhalation burn, and then he had more injuries.
Fell down, did Peter's hands.
It's kind of weird because there's one.
Yeah, and I think they made it sound like she drug him out of that house.
Yeah, so he,
Yeah.
at least didn't push him off the bump, but it break.
All right, so we're gonna talk about acute coronary syndrome today. I am going to try to keep this as EMS related as possible. Acute coronary syndrome is a huge topic, and you could spend weeks covering this topic. So we're gonna try to make it as specific as possible and relevant for everyone in the EMS world. I hate the sound of my own voice, and I've been talking for a while, so please feel free to interrupt me if you have any questions. Why is this important? Heart disease is still the #1 killer worldwide in the United States. And of those deaths, ischemic events still make up the majority. About 53% of all deaths. So the focus of this presentation, as we discussed, is acute coronary syndrome, but defining that and the different categories of acute coronary syndrome, the pathophysiology that's related to it, that helps us understand what's going on, what you guys are going to see in the field in terms of physical exam and what red flags to look out for. And then a lot of this is going to be EKG interpretation and focus more towards STEMIs because that is where we make the biggest difference in the field, right? And then lastly, we're going to briefly touch on field management. So acute coronary syndrome is when you get an obstruction of coronary blood flow and cardiac ischemia, right? You essentially need to have some level of coronary artery disease to develop the classic acute coronary syndrome. There are some variants that fall into the bucket of acute coronary syndrome, like Takotsubo cardiomyopathy, vasospasm that can cause acute coronary syndrome. But in general, this is what we're referring to when we're talking about acute coronary syndrome, is that there's a plaque somewhere in the coronary arteries. That plaque has started to erode or rupture, and then a clot starts propagating, and that clot is what the problem is. That clot develops there, and then it occludes that artery, blocking the blood flow to the distal tissues of the myocardium. So you get damaged heart muscle and ischemia, and then cell death, and a myocardial infarction. So acute coronary syndrome falls into 3 categories: unstable angina, NSTEMI, and STEMIs. There is, significant problems with this nomenclature, in my opinion, and I'm gonna be on my soapbox for like 2 minutes, I promise. First off is, it makes sense in theory. Unstable angina is referring to symptoms that we think is related to acute coronary syndrome. There is some level of acute ischemia going on in the myocardium that's provoking symptoms like chest pain, diaphoresis, nausea, vomiting, etc. But not enough ischemia to cause disruption of membranes and cellular death. So there's no leakage of troponin into the bloodstream, right? And that's the difference between unstable angina and STEMI. In STEMI, you got a positive troponin. Typically, that's from plaque rupture and erosion, a non-occlusive thrombus, or partially occlusive thrombus. So you can see there in the cross section of that artery, you still get some blood through the top there. So you're getting some nutrition and oxygenation to the myocardium distal of that, but you're not getting as much as you typically would, or what those cells need. So you're getting ischemia. The problem with unstable angina is that we don't have an objective test for it, right? There's no way to walk into the ER, and know when you leave the ER that you had unstable angina. So the gold standard for, working this up would be to do a heart cath, like on everyone, right? But even that, if you say you have, non-obstructive coronary disease on that heart cath, you still could have had unstable angina, and vice versa. If you have a 75% lesion that they end up stenting, we don't actually know if that stent or if that lesion was actually responsible for your symptoms, right? And the other problem with that is that, like, even if you get that gold standard test, you can still walk out of the hospital and die from an MI because those plaques still exist, and even those non-obstructive plaques can rupture and cause that clot propagation and it could block off that artery. You go to refib, you die. So we're not well prepared to handle this. So there's just no good objective test. If you want to be a millionaire, you should study cell biology and figure out a way to mark unstable plaques, and you will make a lot of money. I'll get off my soapbox for now. But the other thing I want to say about nomenclature is that STEMIs, we're kind of moving away from that term almost, and we're moving towards the occlusive myocardial infarction term, or OMI. Because as you'll see as we get into this, there's a lot of STEMI equivalents that don't meet STEMI criteria to activate the cath lab based on ACC's definitions, but really are in the same pathophysiology. They have an obstructive coronary artery, and their myocardium is getting ischemic and infarcting. So we want to catch more of those while still treating STEMIs like we know we should. So this gets into this a little bit more. You can see that again, those cross sections of those arteries in an NSTEMI or unstable angina, you'd expect to at least have some blood flow, so you're not getting true cellular death in that ST segment elevation that was EKG. But you may or may not see some ischemic changes, and then when it's NSTEMI, you're going to have a positive troponin versus unstable angina, you're not. So the reason why it's important to ask yourself anytime you're seeing a patient with chest pain or symptoms suggestive of acute coronary syndrome is because obviously STEMIs need to be emergently managed. The only intervention that truly helps in this scenario is revascularization. And you can accomplish that by one of 2 ways. You can give thrombolysis, so systemic thrombolysis like TPA, or you can go in there with a catheter and stent open that occlusion. And so that PCI, percutaneous coronary intervention, has been shown to be favorable over systemic thrombolysis. So we're going to talk about when to do that. So this is again important because time is tissue, right? Every minute that we have not gotten this patient to PCI is another minute that their myocardium is actively dying. And the more myocardium that you have that's dying, the more likely you are to go into VFib and die. The myocardium is a pretty remarkable muscle. It, people think of it as this pump, but it's a complex network of muscle fibers that wring out blood in a spiral manner that is very specific and very sensitive. So if you infarct a small area of your heart, it's going to disrupt the whole thing. So it's really important to catch this early and get as much healthy tissue back as possible. So getting into the physical exam of what you're going to see in the field. This is a pretty classic presentation of what this gentleman looks like. But you always got to remember your ABCs, right? So airway, breathing, circulation. Patients not speaking to you. Is their airway patent? Are they breathing? Do they have a pulse? Do those things first. Then you're going to do your doorway exam. And this is, the majority of the things you need to be looking for acute coronary syndrome. Are they diaphoretic? Do they look like they're pale? Are they uncomfortable appearing? Do they have the Levine sign? That's what this gentleman is demonstrating here. Classically, it's the closed fist against the left side of the chest, held there, but it can also be just an open hand. Anytime someone's clutching their chest, that's probably a bad sign. You of course want to auscultate too. Let's not miss attention pneumothorax and just go down the EKG route. But those are essentially the things you're looking for on exam. So to make sure we're on the same page, I'm going to get into some EKG basics here. There's a lot you need to know about EKGs to be able to read them sufficiently. We're going to focus on the intervals today because that's what's important when it comes to ischemic change on the EKG. So predominantly we're going to be focusing on the QRS interval and the ST segment and the T wave, so the QT interval. QRS is that depolarization of the ventricular myocardium, right? And then the ST segment and T wave is the repolarization of the ventricular myocardium. That's when stuff goes awry. So definition of a STEMI per ACC, new or presumed new ST segment elevation of greater than 1 millimeter in greater than 2 or greater than 1 anatomically contiguous leads, measured at the J point in all leads other than V2 and V3. V2 and V3 are special because they often have mild ST elevation in normal heart tissue. So they get an extra criteria. So for leads V2 through V3, they need 2 millimeters of elevation in men greater than 40 and 2.5 millimeters in men under 40. And then for women, greater than 1.5 millimeters, regardless of age. And then the other STEMI criteria you need to be looking out for is in those left bundle branch blocks, and that's the Scarbosa criteria and or the modified Scarbosa criteria. So let's get into it. So this was a real STEMI that was e-bridged to us. Kudos to Transcare. I think this one's relatively obvious despite kind of the poor baseline there. And we'll get into why this is STEMI in a second. So ischemic EKG basics here. Going through time as the myocardium becomes ischemic, the first thing or one of the first things you're going to see is those hyperacute T waves. And so that's that top box up here. You're going to see a very large, broad T wave. Anytime your T wave is bigger than your QRS, that's a bad sign. So I'd be on the lookout for that. This is an early sign of ischemia. Next, you get ST elevation and or depression. So you're looking at that ST segment and looking for elevation or depression going down. And then a late sign of ischemia or really infarction is Q waves. And so you don't really see that until after an infarction has occurred. So it's not something you're typically going to be seeing early in a STEMI. And it's not always seen either. Lastly, T wave inversions are relatively non-specific, but they can occur essentially any time throughout the ischemic journey of the myocardium. So you're going to see that in STEMIs and in non-STEMIs. and unstable angina. So getting back to an EKG, I would pull this one up as it's a little bit of a cleaner example of what we just saw. So which region of the heart is ischemic? In order to, to call it a STEMI, you have to have two anatomically contiguous leads, right? So in order to figure that out, you have to know what leads are anatomically contiguous, right? So we got to talk about a little bit of physics here. And I won't get into the nitty gritty, and I probably am underqualified to get into the nitty gritty. But the way you need to look at it interpret an EKG is that each lead is sensing vectors of electricity, right? So you have your precordial leads, so V1 through V6, they're sitting on the anterior portion of the heart. So you can think of those as a horizontal plane going through the axial section of the chest, right? And then you have your limb leads and your augmented limb leads. And those are all here in this circle. And you can think of those as kind of like the vertical plane or coronal section through your chest. And because they're each positioned differently, they catch different vectors of electricity. So when you're looking at the anatomic sections of leads, you have your inferior leads, which are 2, 3, and AVF. And so for an inferior STEMI, you're looking for ST elevations in those leads. The lateral leads are lead AVL, lead 1, and V5 and V6. You can see that those are the more lateral precordial leads there. And then you can see on our diagram here that lead AVL and lead 1 are the most left-sided, right? So they're most lateral. And then the interior leads are V2 through V4. Those sit right over the interior portion of the myocardium. Other thing you're going to look for a STEMI is reciprocal changes. Reciprocal changes are essentially the opposite of ST elevations, so ST depressions in the opposite portion of the heart, right? So that makes sense. If electricity is going the opposite direction from that area of the heart, then it's going to do the opposite on the EKG, right? So for an inferior STEMI, you're looking for reciprocal ST depressions in 1 in the AVL. For lateral STEMIs, you're looking for reciprocal depressions in leads 3 and AVR. And in anterior STEMIs, you're looking for reciprocal depressions in 2, 3, and this here, AVF, obviously. So getting back to our EKG we were just looking at, where's the anatomic section of the STEMI? We're looking at leads 2, 3, and AVF. So I misspelled inferior here, but that's an inferior STEMI. And then you can see some reciprocal changes in the lateral leads, 1 and AVL, and some of the anterior leads as well. Well, this is a STEMI.
Yeah.
Look great. So this is clear big ST elevations in the precordial leads, mostly the interior leads, but they extend into V5, V6. And you can also see some ST elevations in lead 1 and AVL. So you're getting some lateral extension there. And then likewise, you're seeing those ST depressions in the opposite section of the heart, so the inferior leads, lead 2, 3, and AVF. How about this? Is this a STEMI? What trick here?
Getting there.
Yeah, it doesn't look good either. So like this wouldn't meet immediate STEMI criteria, right? If you're looking at this, right? So you're looking for ST elevation in 2 contiguous leads, right? So you don't see, 2, 3, and AVF. I don't like the way that ST segment is kind of like upsloping there, but at the J point, there's no elevation, right? You see these ST depressions in the precordial leads, especially V2 and V3, and a little bit more lateral in V4, but not a whole lot of ST elevation. This is a posterior STEMI. So this is one of those ones you gotta be looking out for. So for a posterior STEMI, because we don't have any leads that are looking at the posterior myocardium, you have to look for the opposite of an ST elevation, that's depression, right? So you're looking at ST depressions in V1 through V3, those precordial leads, right? Anterior leads. Opposite of anterior is posterior. You're also going to have tall, broad R waves in those leads. You're gonna have upright T waves and a prominent R wave in V2. So if you remember a normal looking EKG, the QRS usually starts out with a larger S wave than an R wave in V1 and V2, and it slowly transitions to a bigger R wave, right, throughout the precordium. So that's not present in these STEMIs. Go through that in a second here. So you're gonna see that R wave jutting up earlier than it should. You're gonna see the big ST depression in V2, V3, V1, and then you're have an upright T wave. Typically V1 should have an inverted T wave when it's normal. So again, these are the same EKG changes that are just flipped, right? So instead of ST elevations, you have depressions. Instead of Q waves, you have R waves. Instead of T wave inversions, you have upright T waves. So if you take the EKG and you flip it on its back and look through the EKG, it starts looking like more like a STEMI. It's a little bit more obvious there, right? To confirm, you're going to want to do a posterior EKG, and that's essentially just taking leads 4 through 6 and putting them on the posterior, just inferior to the scapula. And in these leads, you're only looking for 0.5 millimeters of ST elevation, and that confirms a posterior STEMI. Now, what I'd say is that when you see an EKG like this, I don't want you to hesitate and wait to do a posterior EKG. I want you to send me that EKG so I can activate the cath lab. And if you have time, do a posterior EKG en route. But usually it's not this obvious, but having this much depression in the precordial leads there, that's going to be, you can tell it's going to be a posterior STEMI. So overactivate, and then we'll deal with it later. But in this case, they did the posterior EKG, and you can clearly see huge ST elevations there. You also, I would argue, this would have met STEMI criteria because it also has elevations in the inferior and some elevation in the lateral leads too. What about this? Is this a STEMI? Put the arrow there already, so looks like a STEMI. Right, we've got big ST elevations in the inferior leads. Got some some reciprocal changes in the lateral leads. Why I brought this up is because this one is inferior STEMI, but it has right ventricular involvement. Okay, so you see the ST elevations in V1, which is a right-sided lead, and then lead 3, the ST elevation is greater than lead 2. And if you get back to our vectors here, you can see that lead 3 is more right-sided than lead 2. And then likewise, V1 is more right-sided than V2. So RV infarction, you want to consider this in all inferior STEMIs, right? The RV is supplied by the posterior descending artery, and the PDA rises from the right coronary artery in 90% of the people. So it's just natural to assume that that artery is going to involve the right ventricle, right? EKG features we just talked about: ST elevations greater in 3 than 2, greater in V1 than V2. Why is this important? Because these people are very prone to hypotension. They are preload dependent, and that makes sense, right? Because the right side of your heart is the first part of the heart that's receiving blood from the rest of the body. It needs to pump blood through your pulmonary circuit back to your left side, or the left side to be able to pump it to the rest of your body. So it's preload dependent. What happens if you give this person nitroglycerin? They don't do well oftentimes. So this is something you got to be very careful with nitroglycerin. To confirm a right side or a right ventricular involvement, you can do a right side EKG, which is essentially just flipping all of the precordial leads to the right side of the chest. Honestly, you might not have time to do that in the field, and I'm not going to blame you for that. It's kind of an exercise in cognition more than anything, because there's other ways you can tell. But in this case, B4R being the right-sided lead, you can see those ST elevations there. So clear right-sided involvement. So before we move on, so just in general about right-sided or right ventricular involvement of inferior STEMIs, I don't think you're ever wrong to just withhold nitroglycerin for all inferior STEMIs if you are concerned. I know our protocol, we are moving towards 120 as the systolic blood pressure to cut off for nitroglycerin. But if you know the patient has right ventricular involvement, then I would be extremely cautious in giving nitroglycerin, unless their blood pressure is like 220 over 140, and you think that the actual hypertension may be contributing to the STEMI. It is generally not a great idea. Nitroglycerin is a great drug in theory, right? It reduces preload, it reduces afterload. It's a vasodilator. It's supposed to dilate the coronary arteries, which is the obstructing problem of the STEMI. But in this scenario, when you're so preload dependent, it can cause significant harm. And nitroglycerin has not panned out to show any mortality benefit in STEMIs. So it's one of those drugs that is great in theory, but on paper and not so much. Whoops. I'll give you the answer here. I was gonna say, is this a STEMI? So again, this is not gonna meet classic STEMI criteria. You see like maybe a little tiny bit of ST elevation in B2, B3, but remember those leads you need a little bit extra to be able to meet STEMI criteria. So it doesn't meet classic STEMI criteria, but this would be something that we can be concerned for an occlusive MI or an OMI. So this is Wellens syndrome. Not classically a STEMI, but highly specific for proximal side. That's kind of a misnomer because it's not really highly specific. It is concerning for proximal left anterior descending occlusion. And those patients do very poorly with just medical management, so they need revascularization. So there's two types of Wellens syndromes. There's deep inverted T waves in those precordial leads, and there's those biphasic T waves that we saw previously. So I'm gonna go back to that real quick. This is the biphasic T wave. It starts up and then it goes down, kind of a sinusoidal wave. And then this is the classic Wellens. This is the majority of Wellens syndrome will look more like this, where you have these big, deep T waves in the precordial leads. Anytime you see this, it's bad. I would not fault you, and please do actually call this a STEMI and transmit it and let the doc decide to de-escalate or not. All right, moving on. Is this a STEMI? It's tough. So this is tough because you have a pace rhythm. You see pacer spikers there before each QRS, so it's a ventricularly paced rhythm. And with pace rhythms, you're going to get that left bundle branch morphology. So there's deep QRSs in the precordial leads that are then upright in the lateral leads. And with those big changes to the QRS, you're going to get ST elevation naturally. So you're going to see some ST elevations after those QRSs. What is concerning to me about this EKG is these suppressions, though. Right? We're going to talk about this more. So this is when Scarbosa criteria come into play. So early 2000s, we went through this phase of calling every new left bundle branch block a STEMI, and then they cath all these people, and then they were like, okay, well, only a small minority of these patients actually have an occlusive MI. So we should probably stop doing that. So in the meantime, these criteria have been developed, specifically looking at a left bone branch block morphology and which of those patients actually have an occlusive MI. So you're looking, so these are the criteria here. The original Scarbosa criteria is concordant ST elevation greater than 1 millimeter and greater than 1 contiguous lead, or concordant ST depression greater than 1 millimeter in leads V1 through V3, and then discordant ST elevation greater than 5 millimeters in any lead. Modified Scarbosa criteria, essentially the same first two criteria, right? So those haven't changed at all. The only difference is that we changed this third criteria to, instead of being this strict, that it has to be 5 millimeters. You have to think about that on the EKG. That's more than one large box. So that's a big ST elevation. We're going to say it's related to how deep that QRS is. So the amplitude of that S wave, if you divide that by 4, if that ST elevation is greater than that, then it's meeting that criteria. So to go through this a little bit further, if you can't remember all these concordant, discordant things, just remember, you dance with discordance, you cry with concordance. Concordance is bad, discordance is good. So normally for a left bundle branch block, anytime you have the QRS that is upright, you should get some natural discordance and have an inverted T wave and ST depression. Vice versa, if you have a QRS that is downward facing, you should have some discordant changes and ST elevation, upright T wave. It is bad when you have concordance. The QRS is up, the ST segment is up. That's not good. Likewise, concordance downward. If you're having a downward facing QRS and downward depression of the ST segment, that is not good. All right, then modified Scarborough criteria is just changing this to be, has to be greater than 25% of that. So the reason why they add that or they changed it is because the Scarborough criteria was very specific. Every patient they cap that meets Scarborough criteria typically has a STEMI, but it missed a lot too. So it wasn't sensitive. So they improved the sensitivity by changing that criteria. That's pretty good now. All right, is this a STEMI? This is another EKG that was sent by eBridge this month. The computer sure thinks so. This is a patient I took care of. I did not call this a STEMI. You can see it, I think that the computer might have been thrown off by this PVC here, but that wasn't present on this one, so it's still reading on this one. I think they might have been thinking this segment right here, the V2, V3. So what you see here is a partial left bundle branch block. You have very mild J point elevation, but I don't think that meets STEMI criteria, right? That's not greater than 2 millimeters in that lead. This patient was a male. And likewise, you need 2 contiguous leads. So we repeated that when they got there. This is not that EKG, but we didn't call it a STEMI. Their troponin was negative. We still admitted them for observation. They did fine. All right. What about this? Is this a STEMI? Getting more and more difficult. This is not a STEMI, but this is an OMI. So this is something to look out for, okay? When you see ST elevation in AVR and diffuse widespread ST depression, that's not a good thing. Typically that's associated with a left main coronary artery occlusion. So the left main artery is what the artery that supplies the left anterior descending artery, which is the widowmaker, right? That's the big one. And then also the left circumflex. So if you get that occluded, then you're pretty screwed. It's not good. So that's nuts. I mean, it sucks because we don't have a STEMI that matches that, right? You have to look for one lead and then diffuse ST depressions. So again, why you need to have a high or a low threshold to suspect a STEMI or an OMI. Again, not classically STEMI criteria, but what would be considered an occlusive MI. All right, so to summarize our EKG findings that we're looking for, if you're looking for ST elevations, ST depressions, Q waves, and T wave inversions, you're never going to miss a STEMI. Then you got to remember your anterior, your anatomic segments of the EKGs to be able to fully define and meet STEMI criteria. All right, getting into management. The old textbooks use this acronym MONA for treatment of acute coronary syndrome. So morphine, oxygen, nitroglycerin, aspirin. We still do most of that. But again, none of this has really panned out to offer any true mortality benefit other than aspirin. And aspirin even isn't that great. We rush to give people aspirin, but there's a number needed to treat of like 16 for aspirin. So for every patient that's having a STEMI, you have to give 16 people aspirin in order to save one life. So still not a great medication. Nitroglycerin, again, great in theory, not so great on paper. It hasn't panned out and it can cause some harm. So you got to be careful with that one. Oxygen, you want to support someone with oxygen when they are hypoxic. You know, you want myocardial tissue getting less oxygen than it's already getting. But you also don't want to over oxygenate someone. So if you hyper oxygenate someone, you can cause worse free radical production following a STEMI, which precludes worse recovery. And then finally, like morphine or any opioid analgesia obviously comes with the adverse effect of respiratory depression, potentially hypotension. So you got to be a little bit cautious with that. The theory, behind why you do that is because if you're improving someone's pain, you're taking away that sympathetic drive that they are typically overactivated with, and which is usually increasing the workload on their myocardium and worsening that ischemia. But again, so all those things, essentially other than aspirin, don't incur any mortality benefit. Main thing you need to make sure you're doing is get those people on the pads, right? These people code and they code fast. They are often pre-fib and pre-tac arrests. These are the people that you will save their life if you get them on the pads quick and recognize they're having a STEMI. And then lastly, like Brooke talked about, everyone needs to be transmitting EKGs when you're concerned for a STEMI. So I finally have access to eBridge, so I'm reviewing all of them. I appreciate, I think Park County sent one yesterday. I didn't end up thinking that one was a STEMI either. That's okay. I want you guys to send us low threshold for calling it a STEMI. Let the doc decide. And then likewise, don't take it personally if the doc doesn't want to activate the cath lab outright. They don't think it meets criteria. They repeat an EKG and that EKG meets criteria, then they have to activate the cath lab. That's fine. But those cases like, a Welland syndrome or, that left main coronary artery, if you send me that EKG, I'm activating the cath lab. And then the team's here 5 minutes earlier. That's 5 minutes earlier to balloon time and potentially, a much broader saved piece of myocardium. So push the button. Save some tissue by transmitting. All right, that's all I had. What questions you guys have for me?
Good, thank you.
Thanks.
What do you think the timeline will be where you can go straight from the ER doors to the cath lab?
We're working on that.
We would do that now if we can. That requires, advance notice that we have the EKG, we've activated the cath lab. The protocol is written though. If the cath lab is ready, the patient is supposed to stay on the cart and the doc does a quick assessment while they're getting registered and they go straight down to the cath lab.
That's actually one of the new guidelines for ACC. They're looking for that in our policy and that we're actually doing it. So the earlier you can transmit those EKGs, we can get the cath lab here. I mean,
What's the
Ideally.
call time for cath lab?
they have 30 minutes.
30 minutes, okay.
Typically,
So that's
30.
probably more likely like during the day, Monday through Friday type situation.
Yes.
Or
Now,
during
I will
class.
say, I mean, there's been several times we've gotten EKGs ahead of time, activated the cath lab, and they may not have gotten straight to the cath lab, but it's just been a short few
Very
minutes.
quick.
Because we're not gonna hold up EMS, right? But
Yeah.
if we're
Right,
ready,
we have to clear
we
them,
want to
yeah.
go, and that's what ACC is looking for our accreditation. They want to see that's in our policy and that we're actually doing it. So when I submit cases, they're looking for that. So, and we're tracking that now. And just like with the, the activations based on EMS EKGs, we're looking, because I think there's some concern that maybe we're gonna be canceling the cath lab a lot. I don't really think it's gonna happen that often. There was,
Sure.
in our chest pain meeting, the one and only case that EMS met our door to balloon time was the one they transmitted the EKG. So I think we're gonna find that we're gonna be doing better if we can keep up this work. And so eventually, as we get things more refined and get our services streamlined, I think we'll see that you guys are just gonna roll straight to cath lab. That's the goal. That's the end goal, so.
It requires like an ER physician is going to look at all these EKGs. So like you're not activating the cath lab, you're telling the ER physician, I think this is a STEMI. What do you think? Do your thing. That's the ball in their court then. And I'm pushing them to be more aggressive about doing it, but we need to be able to see the EKG. We can't, we can't activate the cath lab.
Does it still pop up in the
Blindly,
bubble?
yeah.
Does it still come up on the secretary's desk in the
Yep.
bubble? Okay.
It comes up on the iHearn. I had a case, actually the EKG, this one, it was at night and the secretary pulled up. So they transmitted this EKG and I could see it on my cell phone because I just like got the alert on the E-bridge. But then the secretary pulled up this EKG on the iHearn. I think she just clicked the wrong one. And so I activated the cath lab because I was like, well, that's a semi. And I had to I hadn't looked at E-bridge on my phone, I hadn't really quite figured it out yet. But then I was like, that's not what was on my phone. So and then I figured out it was actually the other EKG they sent me. And I'm like, okay, that's not the semi. So I briefly activated the cath lab and then deactivated the cath lab. But we'll work through those kinks. The more you send us, the better we get at working through it, right?
Do all the providers have eBridge on, like, they have the availability to get?
No,
it?
I just got it, so
Someday, potentially, could all the ED providers have that, or?
I get them. So I don't know that there's a limit on eBridge. There's a limit on like trauma pages and stuff because it's an internal system, but I think eBridge is an external system.
yeah.
But I don't know that they all want it. Because
It's,
that means they would get them when they're not working.
yeah, so that's the problem, and then you have to remember to
But
turn
they
it
are
on.
supposed to carry cell phones when they're here,
We could just log it into all
the ones that
cell
are,
phone.
and then when they're here, they carry the
Like the
phone,
work-
but they are not really good about carrying those phones.
But I mean, the iHearn goes makes the same noise
Right.
that the app does.
Yeah, you
that,
can't ignore it. It's very significant.
So, and if you send us an EKG, like the secretary or the charge nurse is gonna get the physician to come look at the EKG. So, and our bubble sits right there,
And we
right
have,
next to
we
the
have it set up for stroke, STEMI and trauma, so they would get all of those alerts.
Hey, Dr. Jackson,
Yes.
this is Hannah.
Yeah.
I think the ones that we've been able to work out the best are the ones that they call immediately. I don't know if all of it would be pretty nice if they had either the ER phone number in their personal phones or the charge number. But I feel like, I mean, if it takes us 30 minutes to get all of this done, at the very least, if they can call us even from the scene, the second that EKG's done, say, guys, I have a STEMI, and we can get stuff started. I think some of the big delays, even on the long transports, is sometimes they'll send the EKG, but there's no patient's name, or like cardiologist. So I've actually called like the Horizon base before to try to get with the ambulance while they were en route to get that information. So I think the earliest they can, one, get us the EKG whatever way, two, let us know patient and the patient's cardiologist, and then we can easily get it going.
Yeah.
But it's like when we get bits and pieces of it and not the whole thing, we're kind
So
of limited, and sometimes we have to wait till they arrive. Versus if there's a way they can call us and let us know all of that stuff as soon as possible, we can walk them straight through.
Yeah. So the eBridge you don't need to put in a name or anything for that. You can just take a picture with the eBridge app and send it. So
But they should call us with name and date of birth or the patient's cardiologist.
right. So I mean, well, they're gonna call the iHeart, right?
Well, they can't give
Give that information on the
information.
iHeart, because it's open airway, so they're not supposed to
Yeah.
give
You
patient.
get cardiologist.
Oh, you're
They use
saying
cardiology.
like to pre-register them? Is that what you're saying?
Not necessarily pre-register, but they do ask some of those questions. And if they have called
They
us
have-
to pre-register stroke, so if they could call us also on STEMI, that would be helpful.
And if they have an established cardiology, you're gonna call it different. It's gonna make a difference on the phone call that Hannah's team has to make.
The process is a little
Yes.
different.
Right. So I mean, definitely who the cardiologist is. If that is not reported on iHeart, then that should be asked by the secretary to prompt you guys to ask, so we get the right person here.
The problem is they have such short response time. So like the city sometimes, depending on where Transcares runs at, they may only have a 5 minute, like they're doing a
Right.
lot.
So
And
Try
I
to get
get
the
that.
fire, try to grab someone from fire to even call us while you're on scene.
You don't, do you always have them for STEMI? Probably not.
The
I'll say that, you're talking.
I
one
want you
day
to
trying
send me the
do it.
eBridge. I like, so eBridge, iHearn. Okay,
And
let's
when you
start
do,
there.
Is it through your life
Okay.
pack or whatever you have
No, we are mandated e-bridge, people know.
now? Okay.
So if
But like,
they
what's your, oh,
We
sorry,
love
what's
that.
your process though? Like, is eBridge, how do you get that to happen?
We have it on our tablets in the back of the apparatus. And
Okay.
so if somebody has a chest pain, theoretically, before they even start putting on the 12 leads, they should be grabbing a tablet just in case. They do the EKG, and then when it prints out, or they can go ahead and leave it on the screen that's a diagnostic view, they can take a
They
picture.
can take a
of it.
picture. So we're adding steps to their process, the process that we're asking them to trim.
Yeah,
is
I'm
my
asking them
point.
to take a picture and text it.
So if they are transmitting the EKG via eBridge and they call in the iHearn and say, I have a 42-year-old female, chest pain, suspected STEMI, cardiology is Dr. Nambury, is that enough?
Yeah.
Is that what Hannah, is that what you're asking for them to give you, rather than making them have more steps?
Hannah's
to
asking.
pay?
Hannah wants them to be able to automatically register.
But I mean-
so we can-
To not add steps to their process, since they are limited as well.
Yeah,
you know,
that's fine. Some,
that-
what I'm saying
some-
is some groups just send us the EK, just fax us the EKG, but that's not enough information. We have to figure out what cardiologist. So yes, if they can do that, I mean, the
At
EKG
minimum, at minimum.
and the cardiologist, that's it.
Right, so those are the only two pieces we need to activate the cath lab.
Is there anywhere to put
And,
cardiology in
the
there?
iHearn call, this is a 59-year-old male with.
Oh, you have it? That's what they sent. That's a STEMI from Park County. And so that one was, I don't know. Nick, can you add comments to the, like, when this piece, this is what it looks like when we get it.
I don't know, it's updated several times, I'm not sure.
Well, we can ask Larry.
So they can put a patient name in there, but they don't typically do it because I know it's seconds, but like this is Park County, so they obviously would have more response
More
time.
yeah.
These guys don't have that.
And that's fine.
And an
like,
ETA.
again,
An ETA would be good too.
Like that, the name and date of birth is all this for registration. We can
Okay.
still activate the cath lab
Their registration.
prior to registration.
Like this one literally is just a picture of the EKG. Now, sometimes we get more if it's a stroke or a STEMI or a trauma. Like here's one, it's Park County too though. And they told us it was a 61-year-old. Oh, they put mechanism of injury on this one, so I don't know if it prompts different. Time sent 0020. Yeah, I don't know.
And again, for trauma, it's kind of like, I mean, they're gonna iHearn anyways, so it's not as valuable. The eBridge is like, why it's so valuable for this is because this is how we activate the cath lab. We have to be able to.
So that's supposed to be how they activate trauma and STEMI too, or trauma and stroke too, but they don't. Yeah, so when I bring up the STEMI, it doesn't have anything but age and sex.
Yeah.
It does say body. I don't know what it means by that. But then
There's a
the,
body.
It's not just body.
Barry is looking into, the LifeNet situation. It's extra money if it potentially can be used with other systems. The problem is that Terre Haute Fire is the only one with the new life packs. So if we're doing that and it only works for the new life packs, then then everyone else is on eBridge still, and we're paying for two services, so that the hospitals are just not going to do that. If LifeNet can be used with any Zoll or whatever, then I would imagine we would have no problems with switching to LifeNet, but it's gonna just take some investigation and he's waiting for a
LifeNet used to require a module on both ends and it got very, very costly.
We
But
all
I-
have life.
But that was when we
Everybody.
first, we've had that
Don't
forever.
like doing it either.
And I think another part of that LifeNet was specific to STEMI. And this system, they could do multiple things with it. Makes sense. So it's a better bang for the buck.
It is what it is, guys. I mean, like, in order to activate the cath lab, we need to see the EKG. And
Maybe we just need to reinforce,
if
Yes.
there's an ER physician that does not activate a STEMI when it's clearly a STEMI that they saw before the patient comes, I'm gonna be chatting with them. All right, that's my promise to you guys, okay? That are not doing what's right for the patient. No, but that requires that we see the EKG before they get here. So you guys need to send the EKGs. And don't be offended if they don't activate the cath lab.
That's on them, not you guys.
That's on
You're
them.
doing your
Well,
job.
that's a huge step from what it's been before, so I appreciate the effort.
Absolutely. That's what we should have been doing all along, honestly.
I only got, like, it only goes back to, no, this went back to January. Only one of them is Terrifier. I actually thought you guys used
I
it.
was gonna say, I have yet to see a Terra Fire EKG.
I
so,
got one in March.
and a couple Transcare, got a couple Park County.
Lot of Transcare, a lot of Park
We'll
County.
work on it. I'm not afraid to say we don't use it.
Right,
We'll work on it.
all right, yeah.
I say with the Zoll.
Time is tissue. Push the damn button.
But there's no, there's no picture. They did send a STEMI alert, but they didn't send the picture.
All right.
Moral story. Push the button.
Push the button.
Send the picture.
Well, some of that is strictly the timeline. If they're circling the drain, you're thrashing.
Well, yeah, for sure.
Yeah, no, I mean,
You
you're
got
gonna do what's right for the patient, right?
No,
Like,
Right.
it's
A
not
little,
waste time,
most of
right?
it does not.
No, I'm-
to sleep.
Yeah, no, I
We got
100% get it.
But also, then if that's the case, then I'll get on my soapbox and say, document it.
Oh,
You know,
100%.
I'm not you
So
specifically.
it sounds
but
like our opportunities are,
Mhm.
we're gonna take it back to the crews to use it.
Yep.
Dr. Jackson's gonna work with the physicians to carry the in-house phone and we'll make sure that it's on there, right? And then we can evaluate at
I
that
don't
point.
think the phone is gonna help a whole lot.
So how are they gonna see it if it's not on their
It's
phone?
on, it's on iHeart.
It
The
comes up on-
secretary gets it and then they alerts them, right?
It
Okay.
does the
And they're,
wee.
and they're gonna go and they're gonna look, cause I have been out there when they have refused to come and look.
Who?
I don't know any of your physicians, I'm so sorry, they're babies.
Tell me who that is and I
You
will.
got it, it's a deal, because I only go out for traumas and I just happen to be out there. I had words with one the other day when the mom was in the wreck and it was a trauma and I couldn't get him to do a 3-second assessment. She needed to go to OB, he did it, but he was mad, I'm surprised you didn't get a complaint on me. Cause I said, you need to put your big boy pants on and I need you to walk with this patient. But I don't know that he's here, that might have been his last name.
Oh, okay. You know what you're talking about.
He said, oh. Okay.
So the crews are gonna work on using it and you're gonna work on the guys in the docs
Yeah.
acknowledgement, okay. So we have a starting point, are you good with that?
Yep, I
Okay.
like it.
So Brooke, for the semi that you sent that we didn't hit our door needle time, was that transmitted? Do we know?
I don't recall. I have to go back and look.
Because again, if we can't see the EKG, we can't activate.
I think actually she might have been a walk-in, so it might not have been EMS at all, but
Oh,
I'll look. I'll double check that, but, cause I've been trying to keep track of that and, you know, if there's some barrier to using eBridge, please let us know. I know that time is, you know, and manpower, but if you're finding that you're transmitting the EKGs to eBridge and then we're saying we're not getting them, we can look into that. There's all kinds of, you know, things we can look at, but you know, just push the button. We're gonna get everybody t-shirts. Push the button.
I know, like the current, training module for it's kind of out of date. I talked to Barry about it already. The UI just from the current module that is assigned to us and what is actually on eBridge right now is completely different. It does look a little bit different. It doesn't look majorly different. It's not like anybody can't navigate it, but
yeah.
a new training module would be nice that we could send out and have guys review.
It's pretty simple, I would imagine.
It is pretty simple. Yeah, it just looks different. So when guys watch that video and then when they open it up in the heat of the moment, they're kind of,
Yeah,
you know,
yeah.
they do have a little pucker factor.
Billy's coffee can. We'll all have eye stats on the ambulance, then we won't have to worry about it. We'll have a troponin level and everything ready to run.
I like it.
I mean, yeah,
Then we'll cut through all
you're gonna have to
the
work faster.
I saw it's like,
2
wow.
drops of blood.
Yeah, exactly.
After then getting the right side of
If you
it.
get
Yeah.
on a regional, that would
IV.
took 10 minutes to run.
Yeah,
I mean, it's fast, but
I stabbed.
it felt a long time when you were in that
falls
situation.
on
it's
the clear.
expensive, it's.
It falls on,
It's
well,
CLIA,
it's worth, if it's worth it in these scenarios, but it falls under the CLIA contract and that's where it gets very
Yeah.
muddy.
Yep. And it's like temperature sensitive too.
Don't
so,
touch
like,
it, don't
yeah.
move it, yeah.
Yeah.
So our goal is EMS is gonna use it and Dr. Jackson's team's gonna look at it.
Yep.
Okay.
Thank you.
And then Brooke's gonna let us know if that don't work and we'll back up and reevaluate.
Yep. Like it.
Heather, back to you. Sorry.
Yeah, Heather, take it over.
That's my CNS brain twirling.
I don't know, I was trying to stretch.
Did anybody have anything else?
Oh, man.
Yeah. Okay. Nobody
Stay on
else
the
has
code.
Nope. Thanks.
We'll see.
That
was the.
was actually a good situation.
Oh,
Oh, Heather, put it back up. James was scanning it.
didn't work anyway, so.
Oh, I did.
I got you in mind.
I don't know.
Yeah.
It
always
was
got you.
James. Hey, Nick takes care of that.
Yeah, that's
That's good.
I've been meaning to mention it and I forgot.
Hey,